much for inviting me here tonight to speak about a topic that is near and dear to my heart. I've been in practice, I would say, just to give you a bit of a background, maybe since 2002. So, yeah, been in practice since 2002. And I actually do work in another hospital outside of Valley 2 days a week. It's a place, it's another special place for people with chronic developmental disabilities with cerebral palsy. But I certainly see also in that other hospital where I work, children with the whole range of developmental disabilities, with autism being.
Dr. Maravik, can you unmute yourself? I muted you by accident.
Oh, that's why
There you
it
go.
appeared. Okay, all right. So for the next slide, I just like would give you an idea as to the topics and that I will be covering tonight. Let me just see. All right. Bear with me. This was working earlier. Oh, there you go. Space bar. Okay. Can you hear me and see
I
me?
can hear you. Yes, we could hear you.
Okay, and you can see. Okay. So the order of events. So first I'm going to talk about assessment. How do we diagnose autism? And then I'll go over prevalence. How common is it? And etiology. What is the cause for autism? At least at this point in time that we have been able to investigate. Interventions. What do we do once we have a diagnosis of autism? And then finally, I will close with the resources available to us. So assessment. How do we make the diagnosis of autism? So when do we start thinking about a child possibly being in the spectrum? By the way, now since the DSM-5 came out, it stands for Diagnostic Statistical Manual of Psychiatry. So this is like almost like the Bible used by clinicians like me when we diagnose conditions, developmental conditions such as autism, for example. So when the fifth edition came out, what used to be called as autism, Asperger's syndrome, pervasive developmental disorder, all just got subsumed under the new umbrella diagnosis of autism spectrum disorder. So when we say autism, when do we start thinking about this? It's any time when a child presents with delays, developmental delays, as well as qualitative differences in these aspects of development. And that includes communication, social interaction, play, and behavior. Now, it is not just what the child does, but rather how he does it. So what we mean by this, it's not just a quantitative difference, meaning there's a quantifiable delay in development, let's say in communication, with language delay being the most common presenting symptom. But in addition to the quantitative delay, there is also a qualitative difference in how the child plays, how the child interacts with others, how the child behaves. So this is what brings us to the observation that sometimes children in the autism spectrum may do things in an odd way. Now, as I mentioned earlier, the DSM-5, the fifth edition, this is where we refer to when we are talking about the criteria when we make a diagnosis of autism. So as with the next two slides, I'm going to show you what exactly are those criteria that we use when we make a diagnosis of autism spectrum disorder. So the first bullet point you'll see on the screen is deficits in social communication. So deficits in social communication is assessed through these three areas. First is the social reciprocity. So that involves the quality of interactions with other people, with family members, as well as with other children their age. The child's ability or difficulty in holding reciprocal or back and forth conversations. Now, how do we assess nonverbal communication? This is where the lack of eye contact is a major symptom. Sometimes it's one of the concerns that parents bring to me. The lack of gestures, use of gestures to communicate in a child who is nonverbal, let's say, and also unusual aspects of body language. Difficulty picking up on nonverbal cues from other people. And then lastly is relationships, abnormalities in the quality of the relationships. And this takes the form of difficulty or a lack of interest in making friendships, and also if they do make friends, they would have trouble sustaining friendships. There is this lack of interest in peers. And when I talked about play earlier as being one of the aspects of behavior that we really look into, you could elicit a history of lack of imaginative play. Or if there is pretend play, it emerges much, much later than you would expect it. Now, these are often called pragmatic deficits. So when you hear the word pragmatic language deficits, what we are really referring to is the social aspect of communication. So when you're saying that a child is exhibiting signs of autism spectrum disorder, you're essentially implying that this child has pragmatic language deficits. Now, the second part to the criteria for autism spectrum disorder is atypical repertoire of behaviors. For this particular list of criteria, you see 4 bullet points there. The child who is meeting criteria for autism must demonstrate at least minimum of 2 out of these 4 characteristics. So let's go over these characteristics. First is repetitive motor movements, or what we call stereotypies. So this very commonly can present as hand flapping, lining up toys or items, or echolalia. Echolalia is what they refer to as scripting or repetition of words, phrases, sometimes even long or lengthy lines, which later on appears to have been quoted from a favorite TV show or sometimes even quoted from other family members. Um, the second unusual aspect of behavior is the child's insistence on sameness. So this is what we refer to as inflexibility. So sometimes these children have the propensity for wanting things done a certain way, or like in a particular manner, so that as a result of that, very often these children present with significant difficulty adapting to changes in their daily routine, or they struggle with transitions. And this insistence on sameness can also manifest in the children having a very selective, diet, very limited diet. So I would have some patients parents would complain that this child would only eat 1 or 2 things for lunch, breakfast, and dinner. Peanut butter and jelly and sandwich, or just goldfish crackers, or very specific, like just Wendy's chicken nuggets, but not McDonald's chicken nuggets. So very specific, very particular. And then what I mentioned earlier about the rigid thinking or the inflexible thinking. And a lot of times when they can get very rigid or inflexible in the way they think, this is actually one of the driving points of what comes across as challenging behaviors or problematic behaviors when they start acting out. And sometimes when you try to really delve deeper into what is driving that problematic behavior, let's say a big temper tantrum or a meltdown, you find out that it's really because the child initially, or apparently is thinking that you would be, let's say breakfast, be giving him or her what he is expecting, like maybe waffles, or like maybe you presented the waffles but you cut it up, and in the child's mind it should be presented as a whole waffle, not as a cut up waffle, and therefore that's where that rigid thinking comes into play now. And then they start melting down or having an outburst because, again, the lack of communication on the child's part precludes him or her from really just explaining to you that I didn't want you to cut up the waffle. I wanted to have the whole waffle. Okay. Now, the third aspect of behavior is the restricted topics of interest. This is what we call an over focus. So, this is where they actually can have some areas of obsession. It could be a certain character like Barney, or like certain toys, Thomas the Tank Engine, for example, the trains, or certain subjects like the planets or dinosaurs or animals. So they could have these narrow areas of interest, or what we call over focus. And then also, they could have like sensitivities or sensory differences. They could be under or oversensitive to certain aspects of their environment, be it like sensitivity to lights, certain sounds. Like there are some kids who just cannot handle the sound of the siren or the fire drill in school, or like a very sudden loud sounds like the sound of those automatic hand dryers, because that sometimes it could be very loud. Or it could be the smell. Some kids could have like sensitivity to certain smells, or even texture of food. Some kids could be very finicky in that they only want crunchy food. They don't like soft and gooey textures. Or the texture could also be in the form of like clothes. Some kids cannot tolerate cotton or wool, or like when the change of season, when you need to transition from a short sleeves to a long sleeves, they could be very particular about that, and some kids actually have meltdowns over this. When you happen to give them the long sleeves because the weather's starting to turn cold, and they still insist on wearing the short sleeves. So, as I mentioned earlier, back in the DSM-4, which is the previous version of the DSM, we used to have autism used to be divided into Asperger syndrome, which is the high functioning end of the spectrum, and then the pervasive developmental disorder, or PDD, and then lastly PDD, not otherwise specified. But as I said, with the DSM-5, with the latest edition, they did away with all of those differentiation, and they are just now calling it as autism spectrum disorder, to reflect that it is really as a broad range of presentation. From the one end of the spectrum, the low functioning end, meaning the child who is completely nonverbal, very much into his own world, and really just like oblivious to the world around him, and may or may not have also like self-injurious behaviors, to the higher functioning end of the spectrum, where you have a highly verbal child, sometimes even hyperverbal, and high functioning in the sense that they oftentimes have normal intelligence quotient, or IQ, and but they might still have some learning difficulties or learning differences, even though in the higher end of the spectrum. And they might not have as much stigmatizing behaviors, such as the self-injurious behaviors that I was mentioning to you, which tend to occur more in the low functioning end of the spectrum. So, how does the DSM-5 criteria translate to real life concerns? So, let's again go over those criteria that we use to make the diagnosis of autism. So, as far as social communication, when there are qualitative and quantitative deficits in social communication, this manifests clinically as the child not making eye contact. Or if the child does make eye contact, it is not sustained. It's very fleeting. Or the child makes unusual sounds. So these are the children who presents with language delay. So they either just make vocalizations, or if they do talk, if they are verbal, there's unusual quality to their speech, like a sing-songy prosody to their speech, what we call the pedantic tone. Or sometimes some of these kids might even speak with an accent that you would not expect given their background. Or they might talk in a very formal way, almost like a little professor, especially the ones who are verbose. Now, also another way that the social communication deficits could present is in terms of their social interactions. These kids would prefer to play alone in the playground, or if they do engage with their peers, they you find that they have trouble sustaining those peer interactions. They might start off playing with them, but then eventually drift off to play by themselves. Or if they do engage with other children, they might tackle on their peers, not knowing that this is something that you would have to do in a certain way, in a more diplomatic fashion. Or they might have trouble understanding sarcasm or jokes. This is where the nonverbal aspect of communication comes into play. Or they might misperceive, and their feelings are easily hurt, um, even when the remark or comment from a peer might not have been intended in that way. You know, they might find it offensive when there was no malice to that comment made by another peer. Now, in terms of the behaviors, so if you remember, one of the unusual aspects of behavior that I mentioned earlier is the repetitive behaviors. So this could come across, manifest as pacing back and forth, body rocking, jumping in place, flapping when they're excited or when they're distressed, or even walking on their toes. Now, the echolalia, as I mentioned, is repeating words or phrases. So it's like an echo, and it says lining up toys and objects. Or if they do play with toys, they would play with toys in unusual ways. So instead of playing with a car by moving it back and forth and making the accompanying sound of a car, this child might actually go lie down on the floor and just move the car at his eye level and just moving it back and forth, seemingly mesmerized by the movement of the wheels. Or they might actually turn a car over, and instead of pushing the car back and forth, they would actually just spin the wheels of a car. So that is an example of an unusual play with toys. Now, and I talked about the fixations. Thomas the Tank Engine is a big fixation for some reason in a lot of children in the spectrum, or also dinosaurs. And the older children, they might have an intense interest in capitals, state capitals or logos for that matter, or certain characters, Pokemon, like that. And the sensitivity that I mentioned to you could impact eating, of course, if they're very sensitive to the food texture, sounds. And because of that sensitivity to sound, there are some children in the autism spectrum who have trouble in overstimulating environments, such as big birthday parties or loud places like crowds, for example, or like theaters or like fairs, carnivals that might prove to be overstimulating for them. Oh, sorry. So, who are the professionals who may be involved in making the diagnosis? So the diagnoses are often raised by the parent, general pediatrician, a psychologist. If the child has been evaluated by a psychologist in the school or outside the school, speech and language therapist, if the child is working with a speech therapist, or oftentimes it's the teacher as well, or staff from school. Now, the diagnosis. So when these concerns are raised, who do parents typically go to for guidance and for diagnostic for the diagnosis? So first and foremost is a developmental behavioral pediatrician like me, but given the long wait lists across the state and even just across the country for that matter, because there's not a lot of us unfortunately in this field. Pediatric neurologists do also make the diagnosis of autism. Child and adolescent psychiatrists definitely, and in some states, psychologists can also make the diagnosis of autism. Now, what is involved in making a diagnosis? So that's why this is one reason why we do have a long wait list for developmental behavioral pediatricians like me, is because we actually take an inordinate amount of time just covering all of these things on the screen. So we go over a thorough developmental behavioral history of the child. We go over the child's medical history. So this is all through the format of parent interview. And then during the visit, the face-to-face encounter, That's when we do our direct observation and we interact with the child, and then we make our assessment in terms of the quality of the child's interaction with us, the quality of the child's interaction with the parent who accompanies the child, and if there happens to be a sibling with the child during the visit, we also can get that collateral information on how the child actually interacts with the sibling. And then we also go through assessments, formal testing instruments, such as we do formal testing of the child's cognitive skills by doing some standardized testing in the office, language skills, motor skills, as well as their adaptive skills. We, as I mentioned earlier, through observation and directed play with the child, we assess the quality of their play, and then we collect a lot of rating scales, lots and lots of rating scales, which are completed by the parents, the therapists, as well as the teachers working the child. And this is again with the ultimate goal of just getting a global picture of the child in different settings, in school, at home, and in therapy. And then in recent, just within this year, actually, within the past year or year or two, the artificial intelligence tools are emerging already. The Cognoa is a software that has just been approved uh, by um, by the FDA, and it's based on a software that has healthcare providers as well as parents filling out the software, and then the software running, an algorithm on that, and then figuring out whether or not, yes, this child meets autism spectrum criteria, and no, this child does not meet it, or no test result, meaning they could not tell otherwise based on the input that was placed in the program. Now, the I think the main thing I'd like to highlight is there is no one test or assessment tool that we use to diagnose autism. And most importantly, currently there is still no blood test, no diagnostic imaging study, let's say, that can diagnose autism. So it's really, as you can see, it's a highly subjective diagnosis in a sense, because we're basing it up a lot on parent report, teacher's report, and then our direct observations of the child within the 1 hour plus that we get to see the child in person in the office. So you could just see how this diagnostic process is fraught with a lot of bias and a lot of subjectivity in a sense. But so we try to balance that by making it as objective as we can, by gathering as much data from different observers, teachers, parents, coaches, therapists, that we can, just to make it as objective as possible. Now, what are the challenges in the diagnosis? Studies have actually shown that the diagnosis can be made as early as 18 months, no, 1.5 years old. But this can be difficult at this younger age group, just because the full diagnostic criteria may not yet be observed. So, for instance, at 18 months, you don't expect imaginative play or pretend play yet. And at 18 months, certainly you don't expect interactive play yet to emerge, right? And then, so that's one of the pitfalls of the diagnosis. Children with language delay and anxiety can be referred due to concern for autism. So, from a diagnostic point of view, this is one of the things that I often grapple with, especially when I see kids who are, I would say, not your typical child with autism, meaning they can present with a language delay. And then together with that, I am also like feeling that there's a lot of anxiety going on in the child as well. And sometimes a language delayed child with a lot of anxiety can look so much like a child on the autism spectrum. So this is where, as a diagnostician, that is my role, is actually to hopefully be able to tease that apart. Now, children with significant developmental delay, or those with intellectual disability, the old term for intellectual disability being mental retardation. So children with that condition can actually exhibit some behaviors that are seen also in individuals with autism. So this is the big overlap there. But then they do not fulfill the full diagnostic criteria. So this is one of our differential diagnoses: is children with intellectual disability, or children with significant developmental delays, not just in language, but in other aspects of development as well. And then finally, you have those kids which are just quirky, just unusual or socially awkward. And then together with that, they might have some of those odd motor movements, which not every kid that flaps, I tell parents, this is in the autism spectrum. Because I certainly can see some kids with some stereotypic behaviors of flapping and pacing, but it's not autism. Now, prevalence, how common is autism? In the 2020 autism diagnosis study, they've actually pegged the current prevalence in 8-year-olds, at least in 11 communities across the United States that they've looked into, as being 1 in 36. So that accounts for around 2.6%. And in New Jersey alone, it comes close to that, 1 in 35. So this is actually an increase in prevalence from the 2018 time point when they last made the determination. Now, 1/3 of those children diagnosed with autism actually have intellectual disability as well. So this is a high comorbidity there. And boys affected more often than girls. Nationally, the ratio is as much as 4:1. And I would attest to this clinically. Definitely in the office setting, I would attest to this 4:1. That's how often this is manifest more in boys than in girls. And interestingly enough, in this most recent 2020 ADDM network study, they found that Black, Hispanic, and Asian, as well as Pacific Islander children, are more likely than white children to be diagnosed with autism. And this is the first time that it has been documented actually in the ADDM study. Now, identification is so important. It's because we've learned from all of the many years of research that has been poured into autism that early intervention does matter. Early intervention does make a difference in terms of allowing these children to reach their full potential. But despite that, unfortunately, less than half of children receive a diagnosis by 4 years of age. Remember how I told you in the other slide that they have shown that we could make a diagnosis as early as 18 months. But unfortunately, between the combination of a long wait list for clinicians, and as well as sometimes also in the, believe it or not, parents being told different things by their pediatrician or by their friends that, he's a boy, of course it's going to be delayed in speaking, just give it some time, he's a late bloomer. And between all of that, this delays the diagnosis furthermore. So that almost 85% they found had raised concerns about the development of their child by 3 years of age. And even look at this, even parents often have developmental concerns prior to the child's first birthday. And again, as I said, identification and diagnosis depends on the access to resources. So why is the prevalence increasing? I think a big part of this is because over time there has just been an increased awareness of autism. So we've come up with better identification tools. The screening of young children now, it's automatically included in the pediatrician's yearly well check. They've actually mandated pediatricians to be doing in the 36-month checkup, definitely, and in the 18-month checkup. And some pediatricians even do in the 24-month checkup screening tools for autism, such as the MChat or the POSI. And as a result of this, we are now able to identify milder cases. And also, I think studies have shown that the prevalence might not really have actually increased. What happened is with the shift in the criteria made for autism, people who used to be classified as having intellectual disability are now meeting criteria for autism. So there has been a shift now in terms of the numbers, and that might have accounted for some of the increase in prevalence. They are being reclassified now as having autism. Now, premature birth is a known risk factor for autism, and because there are more premature infants now, that are surviving because of the advances in technology, and therefore, because that is one of the biggest population at risk for autism, we have subsequently seen an increase. And then, of course, there's still other factors which are yet to be identified. Now, what is the cause of autism? So, studies have shown that there is a high association of autism in children with prematurity, advanced parental age, and maternal autoimmune disorders during pregnancy. However, I would caution you that just because there has been association that has been shown in some clinical studies, it does not necessarily mean causation. Now, genetics play a very, very big role in terms of the etiology of autism. Studies have actually shown that if one twin has a diagnosis of autism, there is an increased likelihood that their twin will also have autism. Now, if a child has a diagnosis of autism, a younger sibling has as much as 14 times the risk of developing autism. If not autism, the other siblings are at risk for language delay or other developmental disorders. Now, in families, if a child has autism, there is also an increased likelihood that a close relative, like a cousin or an uncle, might have a diagnosis of autism. So, this actually emphasizes to us the genetic underpinnings of autism. Now, in addition to that, there are also certain developmental syndromes which have a high likelihood of autism, and I just listed them for you: Fragile X, tuberous sclerosis, Down syndrome, Turner syndrome. And this is the reason why when we diagnose children with autism, especially if it's associated with some findings on our physical examination, we then would recommend doing some genetic testing. So, what is the medical evaluation of a child with autism look like? So, as I mentioned, because of the association with certain genetic syndromes, we as a baseline testing, would order a testing for Fragile X, microarray, which looks at deletions and duplications in the gene. And as a basic testing, I always order a baseline hearing evaluation. Any child with language delay specifically should have an audiology evaluation, and then an at least a vision eye exam, a formal eye exam, definitely by the time they hit kindergarten. And then in recent years, the genetic testing has become more and more sophisticated. We now have this whole exome sequencing of the entire human genome. And as I said, this is predicted to become the standard of care already in the future. Now, additional studies that are ordered depending on the child's specific findings or on physical examination as well as profile. We may or may not order blood count, especially in a child who's a very restricted diet that you're concerned about anemia, lead level, especially if this child mouths objects, and then specific genetic or metabolic studies as dictated by, again, the physical exam findings and neurologic exam findings. So the imaging studies like MRI or CT scan of the brain, EEG, if it's concerned about seizures. So these are all case-to-case basis, thyroid function tests. Now, not just children with autism, but children in general are hard to get a blood test, right? So, but we do not defer the standard of care, meaning ordering the required or the medically indicated testing just because the child is hard to test. Now, what has not been proven to cause ASD? So I'm sure a lot of parents are in the internet nowadays, and there's so many things that you read in the internet. But let me just at least set the record straight that vaccines, dietary deficiencies, environmental toxins. There was even a CDC study done in a Brick Township of New Jersey where they have found a very unusually high case rates of autism. None of this things that I've listed on my slide have been proven to cause ASD. And when I mean proven, that there actually have been clinical research studies done to look at specifically into this possible etiologies. Now, interventions. After you make the diagnosis, what can we do? So these are the standard of care is what we call ABA, Applied Behavior Analysis. So this is an instructional technique where you actually, the purpose of which is to teach the child new skills, simple skills such as paying attention, making eye contact, imitating actions, and learning from others. Building skills, once you're able to build these skills, like making eye contact, let's say, or teaching the child to use his language, once he gets the language available for him, use it to communicate what he wants, what he needs. So you are actually essentially building skills which will then subsequently reduce inappropriate problematic behaviors. And also part of the ABA is we can use it to help extinguish undesirable behaviors which interfere with learning, such as I mentioned to you, a lot of times there are challenging behaviors in children with autism, like the meltdowns, the temper outbursts, the anger outbursts, which can then not just cause the child harm or other people around the child harm, but can be a big hindrance to learning and participation in therapies. Now, so ABA is a type of educational instruction. There are also behavioral strategies that are used, and these are usually employed by trained behaviorists, or what we call BCBA, certified behavior analysts. So these are just the different types of ways of you can shape and change behavior. Now, what are the evidence-based interventions? There is the Early Start Denver model, which can be utilized for children between 18 to 30 months, and as well as the ABA I mentioned earlier, and a developmental or floor time approach. Now, of course, speech and language as well as occupational therapies are equally important in the interventions that we put into place right away. And this is meant to work on specific delays in language, in fine motor skills. And there's the children who are nonverbal, then we have to find ways of alternative ways of communication, such as teaching them sign language, picture exchange communication system, or the PECs. And the iPad now has this very neat program called Prolo Q to Go. And they have actually come up with very, as I said, sophisticated ways of teaching the child who is nonverbal to be able to communicate his needs by the child just being able to use eye gaze sometimes to point to an icon to indicate what they what they would like to say. And then for older children, you have the social skills training. Socially thinking is an example of a curriculum that's used. Now, what are the non-traditional alternative treatments which have not been proven to be effective? So back in when I was in training back in the 1990s, secretin was a big thing because there was something that came out from a journal that touted its significant positive effect on children with autism. So they've actually conducted studies outside of that journal and have actually disproven the claim of that particular study using secretin as not really having any significant effect on treating the core symptoms in autism. Chelation, antifungal, like, you would find some kids on mega dosing of those antifungals, restricted diets. GFCF stands for gluten-free, casein-free diet, hyperbaric oxygen, auditory integration training, sometimes homeopathy. Now, all of these interventions here, which are not proven, they take time, they take money, and a lot of emotional energy, which are better channeled, I tell the parents, to interventions which have been proven to work. Now, we also, as part of the overall treatment of children with autism, we also have to look at the whole child. So, although there is the diagnosis of autism, we have to look at the entire child, meaning if there's any medical conditions that are also co-occurring, we need to treat those, such as seizures. There is an increased risk of seizures, by the way, in children with autism. Constipation, they have a lot of gastrointestinal issues as well, such as constipation, allergies, lactose intolerance. And this is, I think, what sometimes supports the claim of some parents to me that ever since I started this child on a gluten-free, casein-free diet or lactose-free diet, I've seen some changes in the child's behavior. And as long as a child's diet is pretty balanced and the child is not nutritionally compromised, then that is one area where I sometimes don't really make such a big deal, or I don't really push it with the parents of having them give up that, particular restrictive diet that they have decided to implement, as long as I feel that the child is nutritionally good. Eczema. So any of these things that's listed in here, by the way, are the things that I usually run down with my parents when they start calling me, telling me, Doc, behaviors were so much better like last month when we saw each other, but now they have just gone south. And before I jump to any conclusions, or like if I have a child on medication, before I even make those adjustments, I make sure that I go through this list that's in front of you and just see if any of this could be contributing to the changes in behavior that I am seeing. Now, medications. Okay, so there are medications that are currently being, studied, oxytocin being one of them, because this is a hormone that has been found to be involved in attachment. CBD are also under investigation, but as of this time, there has not been clear guidelines here or consensus yet of efficacy of these modalities. Now, but if you ask me from a clinical standpoint, what is clinically relevant on a day-to-day basis when treating children with autism, when we're talking about medications, it is really not medications to treat the core symptoms of autism. The medications often, when we prescribe them for children in autism spectrum disorder, is really meant to treat either the coexisting ADHD or the coexisting anxiety or the irritability. So ADHD, anxiety, and irritability are very oftentimes coexisting with the diagnosis of autism. Now, early identification, as I mentioned earlier, this is the most, if there's one thing I'd like to take away from this talk tonight, is that early identification is so crucial and so critical. So that if you or someone is concerned about your child's development, you have to seek evaluation. And given the long wait list, I tell parents this, you might as well call, because most likely by the time you call, you would have several months of wait anyway. So during that time, at least you have set the wheels in motion. Now, early identification, of course, leads to early intervention, which I said can definitely change a child's trajectory and developmental outcome. And then separate from the professional therapy of speech therapy, occupational therapy, social skills therapy, the parents themselves need to engage with the child and not just rely on electronics to be entertaining the child or to be relating with the child. Although the children can learn a lot of educational content from electronics, they really learn best and more successfully through various modes of information delivery. And that is what you get out of direct people to people interaction. And that is where they learn to regulate their emotions and their social communication skills. Now, where to get early intervention services? So in New Jersey and across the United States, every single state has the early intervention services available from birth to 3 years of age. All you have to do, parent can call, doesn't have to be a healthcare provider, could even be a teacher, but usually for early intervention, they need to speak with the parent. So it's a parent with any concern, you call that number on the screen, and then you will be in touch with an intake coordinator who would ask you to explain more about your concerns. And then after that intake on the phone, they will then send somebody to your home. Usually it's a physical therapist or a speech therapist or a special education trained professional who will then do further developmental evaluation in the home and then tell you whether or not your child is eligible for services via early intervention until age 3. Beyond age 3 years and older, children then can go to their school district, to the Office of Special Services, which we call in New Jersey Child Study Team. And then a parent can request for an evaluation to see if the child is eligible for special education services. All you have to do is put this in writing, and by law, they have to respond to your writing within a certain number of days, and then tell you whether or not they will be able to meet with you, and where you're supposed to bring your child, and they will be going over your concerns with your child in that meeting prior to initiating a child study team evaluation. And then lastly, private insurance. So this took a lot of lobbying, but eventually it did get passed. By law in most states, health insurance must cover applied behavior analysis and other therapies for children with autism spectrum disorder, unless the company is self-insured. Now, resources. So this is the last slide for my talk tonight. So on the board in there is the CDC, which has a wealth of information. But in addition to that, Autism New Jersey, autismspeaks.org, and the Autism Society.org. Those are very good resources. I would rather direct you to this legitimate source